Esophageal tumors break down into two broad categories: benign lesions, most commonly leiomyomas, and aggressive malignancies. The malignant side is dominated by two histological types: squamous cell carcinoma and adenocarcinoma. Historically, squamous cell carcinoma, or SCC, has been the most common esophageal cancer globally. Topographically, it has a strict preference for the middle one-third of the esophagus. Adenocarcinoma presents a completely different epidemiological footprint. It localizes predominantly in the lower one-third of the esophagus. While it has long been the dominant type in the Western world, its incidence is currently climbing in multiple regions globally. This split-screen matrix breaks down exactly why these two cancers present so differently. Looking at the left column, the risk profile for SCC is extensive. It is heavily driven by chronic irritants: smoking, heavy alcohol consumption, heavily smoked or preservative-rich foods, and the chronic consumption of scalding hot beverages. Regional habits like chewing betel nut or drinking yerba mate also populate this list. Beyond direct ingestion, SCC is tightly linked to low socioeconomic status, exposure to fungal toxins, prior radiation exposure, and a history of other upper aerodigestive tract malignancies. The list of associated pre-malignant conditions is equally long: tylosis, achalasia, Zenker diverticulum, and corrosive strictures all physically stress the mucosa. Systemic issues like Plummer-Vincent syndrome, as well as vitamin E and selenium deficiencies, complete the profile. Compare that to the right side of the matrix. The risk profile for adenocarcinoma is remarkably narrow. While smoking plays a role, the dominant drivers are gastroesophageal reflux disease, the resulting Barrett's esophagus, and Crest syndrome. This clinical dichotomy points to a distinct pathophysiology. SCC arises from a broad spectrum of chronic mucosal injury, nutritional deficits, and exogenous toxins. Adenocarcinoma, by contrast, functions almost exclusively as an end-stage consequence of chronic acid reflux mutating the lower esophageal lining. Regardless of the histological type, the earliest and most consistent symptom of esophageal malignancy is progressive dysphagia. The chronological onset of this dysphagia is specific. Patients initially struggle to swallow solid foods. As the tumor mass expands and the lumen narrows, this difficulty systematically progresses to include liquids. By the time systemic features emerge, the disease is advanced. Patients experience severe weight loss driven by mechanically reduced oral intake and malignancy-related cachexia. Anatomically, if the patient presents with hoarseness, it strongly indicates that the tumor has invaded the left recurrent laryngeal nerve. The presence of a clonic cough is another late-stage red flag. It suggests the tumor has eroded through the esophageal wall and created a tracheo-esophageal or broncho-esophageal fistula, allowing contents to spill directly into the airway. These side-by-side outlines show how we visually distinguish malignancy from its primary clinical mimic, achalasia. On the left, a barium swallow of an esophageal tumor reveals irregular, asymmetrical margins, often described as an apple core or rat tail narrowing. On the right, achalasia presents with a smooth, symmetrical bird beak taper. Clinically, achalasia also presents differently. Dysphagia affects both liquids and solids equally early on. While esophageal manometry is the test that formally confirms achalasia, upper GI endoscopy is an absolute requirement in these patients. You must directly visualize the mucosa to definitively rule out a hidden malignancy masquerading as a simple motility disorder. The diagnostic index of suspicion relies heavily on the patient's timeline. Progressive difficulty with solids, followed by liquids, points toward an expanding mechanical mass, demanding immediate oncological investigation. The diagnostic pipeline for suspected esophageal cancer begins with a single gold standard: upper GI endoscopy with biopsy. It is the only modality that secures both direct visualization of the tumor and the tissue sample required for definitive diagnosis. Once the histology is confirmed, the focus shifts entirely to systemic staging. PET-CT is deployed to scan the entire body, identifying the extent of regional nodal disease and mapping any distant metastases. During this systemic workup, the liver requires specific attention as it serves as the most critical and frequent site for distant metastatic spread. This schematic illustrates endoscopic ultrasound, or EUS. Once distant metastasis is ruled out, EUS is the definitive investigation for establishing the local T stage and evaluating nearby regional lymph nodes. Standard endoscopy only shows the surface of the tumor. EUS uses sound waves to penetrate the esophageal wall, allowing clinicians to measure the exact microscopic depth of tumor invasion. That measurement is the basis for all surgical planning. In gastrointestinal oncology, T stage is dictated entirely by vertical depth of invasion, not by the surface area of the tumor. Because of this, depth of invasion stands as the single most important prognostic factor for the patient. This cross-section maps the T stage progression. It begins with TIS. Once the tumor breaks through the basement membrane into the lamina propria, the muscularis mucosae, or the submucosa, it becomes a T1 lesion. Progression to T2 occurs the moment the malignancy invades the muscularis propria. A T3 designation means the tumor has pushed completely through the muscle and into the adventitia. And finally, T4 indicates that the tumor has broken free of the esophagus entirely, invading adjacent anatomical structures in the chest or neck. This staging system applies cleanly to the body of the esophagus. But when a tumor sits precisely at the gastroesophageal junction, its biological behavior becomes ambiguous. To determine how to treat these, surgeons use the Siewert classification. Siewert type 1 classifies tumors where the center of the mass lies between 5 cm and 1 cm proximal to the GE junction. Siewert type 2 covers tumors centered from 1 cm proximal down to 2 cm distal, directly bridging the junction itself. Siewert type 3 identifies tumors centered deeply below the junction, between 2 cm and 5 cm distal. This topographical map dictates the surgical approach. Siewert types 1 and 2 behave like esophageal tumors and are managed strictly as esophageal cancer. Type 3 behaves like a gastric tumor and is managed according to gastric cancer protocols. Once staging is complete, this algorithmic flowchart dictates the intervention. For very early disease, specifically T1A lesions, the tumor remains above the submucosa. Because the major lymphatic networks reside within the submucosa, the risk of spread is exceptionally low. Treatment concludes with a simple endoscopic mucosal resection, or EMR. The clinical calculus shifts entirely for T1B and T2 tumors without nodal involvement. Because these tumors invade the submucosa or deeper, the risk of hidden lymphatic spread increases dramatically. Endoscopy is no longer sufficient. The standard of care requires a full esophagectomy. For locally advanced disease, including T2 lesions with positive nodes, T3 and T4 tumors, surgery alone will fail. The algorithm mandates neoadjuvant chemoradiotherapy first. This combined approach acts as a radiosensitizer, shrinking the primary mass and clearing microscopic local disease before the surgeon ever makes an incision. There is one major anatomical exception to this surgical pathway. Tumors in the cervical esophagus are typically managed with definitive chemoradiotherapy. Operating in this tight space often requires sacrificing the larynx, so organ preservation takes priority whenever possible. The entire management protocol hinges on tissue layers. The microscopic depth of the lymphatic networks directly dictates the macroscopic scale of the clinical intervention. When an esophagectomy is required, the surgeon has two absolute oncological goals: achieving an R0 resection, meaning zero microscopic residual disease, and extracting a strict minimum of 15 lymph nodes for pathological evaluation. To guarantee an R0 resection, the surgical margins must be massive. Guidelines mandate 10 centimeters of clearance proximally and 5 centimeters distally. This accounts for the longitudinal run of submucosal lymphatics, which frequently seed microscopic skip lesions far from the primary tumor. To achieve these margins, surgeons utilize three primary approaches. The transhiatal or Oranger approach targets lower one-third tumors. It requires an abdominal incision and a left neck incision, relying on blunt mediastinal dissection through the hiatus to free the esophagus. The Ivor-Lewis approach is deployed for middle one-third tumors below the aortic arch, as well as lower tumors. It requires an abdominal incision combined with a right thoracotomy, and uniquely, the anastomosis is completed within the thorax itself. The McCown, or three-field approach, is built for upper and mid-level tumors. It demands incisions in the abdomen, the right thorax, and the left neck. This aggressive access provides the highest degree of lymph node clearance. Following the resection, continuity of the GI tract must be restored. This wireframe demonstrates the best and most common reconstructive conduit. The stomach is stapled into a long, linear gastric tube and pulled up into the chest or neck. The viability of this entire conduit depends on preserving a specific vascular lifeline. The primary blood supply sustaining the gastric tube is the right gastroapoploic artery, supported secondarily by the right gastric artery. The surgical architecture is a direct response to the tumor's location. Its precise spatial coordinates dictate exactly which body cavities the surgeon must open to ensure both oncological clearance and reconstructive viability. Postoperative care requires aggressive monitoring for standard complications like atelectasis and pneumonia, but the immediate threat to life is an anastomotic leak. While leaks are more common when the connection is made in the neck, they are drastically more lethal when they occur in the thorax, rapidly causing mediastinitis. For patients who survive the acute recovery phase, anastomotic stricture stands as the most common long-term postoperative complication. Surgeons must also monitor for iatrogenic thoracic duct injuries. This presents as a chyle leak, producing turbid output in the surgical drains. The diagnostic clue is a sharp increase in that turbidity immediately following a fat-rich diet. In cases of advanced, unresectable disease, tumors often create malignant tracheoesophageal fistulas, causing recurrent expiration and pneumonia. This diagram shows the preferred palliative management, a self-expanding metallic stent, or SEMS. Deployed endoscopically, it physically bridges the fistula, blocking spillage into the airway. While a SEMS effectively improves swallowing and protects the lungs, it is strictly palliative. The most frequent complication clinicians manage with these devices is stent migration down the GI tract. Contrast all of this highly invasive oncology with benign esophageal pathology, most notably the leiomyoma, a smooth muscle tumor presenting predominantly in males. It shows punched-out smooth margins on barium imaging. Because it is benign, treatment is conservative, relying on simple enucleation or submucosal tunneling endoscopic resection, leaving the mucosa intact. The entire algorithmic management of esophageal cancer relies on a strict sequence of logical steps. Progressive dysphagia prompts endoscopy. EUS determines depth. T-stage dictates using an EMR or escalating to neoadjuvant chemoradiation. And ultimately, curative intent demands an esophagectomy, rebuilt via a gastric tube.